The topic of lecture is treatment options of pulpitis. Lecture outline such issues: introduction to the topic, treatment options of pulpitis, basically conservative method, surgical method, indications and contraindications to vital and devitalized pulp amputation and extirpation, steps of endodontic treatment, antiseptics and their delivery into root canal, sealers that are used in the case of pulpitis, and ways of root canal obturation. Pulpitis, it is inflammation of the dental pulp. The common reason of pulpitis is caries and its progression. As well, it can be due to traumatic injuries, accidental pulp exposure during caries cavity preparation or habitual trauma, as well as temperature and chemical stimulation that reach pulp. From this point of view, a pathogenic therapy of pulpitis is based on reparative and protective functions of it. And I recommend you to revise functions of the pulp tissue. They are as follows. Protective function mobilizes defense cells when bacteria enter it. Reparative function. The pulp responds to insults, bacterial, iatrogenic, and rheumatic, in the case of restorative techniques, with an inflammatory process. Nutritive function or trophic. It provides nutrients to the odontoblasts. Sensory function. The pulp responds to injury with pain. It is one of the most important functions of the pulp. And dentinogenetic function. Odontoblasts are responsible for dentine formation and can generate a process of collagen fiber mineralization from the predentine. But when it goes about the pathogenic therapy of pulpitis, this is based on protective and reparative function of the pulp. Propose to your attention such criteria that can be used for successful treatment, and they are as follows. A general condition of the body, the patient's age, location and the development of caries process, the virulence of microorganisms, ways of bacteria penetration into tooth cavity, cause of disease, duration and stage of inflammation, topographic and anatomical features of the tooth cavities and root canals, and periodontal status, and so on. Such methods of pulpitis treatment available. They fall into two big categories: conservative and surgical. Conservative is preserving integrity of entire pulp. Surgical divide on methods with anesthesia. They are vital amputation and vital extirpation, and devitalized methods. This means that for these treatment options I use devitalizing substances. That's why devitalized methods can be amputation and extirpation as well. If there is a combination of usage of few treatment methods, so we can talk about combined method of pulpitis treatment. Conservative method of treatment is aimed at reducing the inflammation and renewing of pulp function. Surgical method of treatment is aimed at total or partial removal of pulp from a previously anesthetized tooth or extraction of pulp after using devitalized substances. Conservative method or biological, it is a synonym. This method is indicated in such cases: pulp hyperemia, acute limited pulpitis, traumatic pulpitis, accidental pulp exposure during caries cavity preparation, chronic fibrous pulpitis without clinical and rentgenological signs of apical periodontitis. So the method of conservative treatment of pulpitis is recommended in the case when patient is younger than 30 years old, and actually this can be explained due to the plastic and reparative function of the pulp tissue. only in these individuals who are under 30 years old, pulp tissue can positively respond to the therapy that is used in the conservative method of treatment. As well, this method recommended to do when inflammation has a short period, not longer than 3 days. Carious cavity has central location and patient don't suffer any general diseases and there is no pathological changes in periodontium. Conservative method as well has its contraindications, and they are as follows. A sharply positive reaction from the periodontium, signs of generalized periodontitis, decrease of pulp response to electrical excitability over 40 microamperes, X-ray changes in the periapical tissues, teeth that will be used as abutments under the bridge structures, inflammation of the pulp in patients with clinical manifestations of chronic odontogenic intoxication, pulpitis in patients older than 45-50 years, and a carious cavity in the cervical area or root caries. All of that are contraindications, and usually they are opposite to indications. A conservative method of treatment normally is done using these two techniques, indirect and direct way of pulp capping. So in very deep cavities in which the pulp is nearly exposed, hard satin calcium hydroxide cement is applied to this area only. Here you have this nearly exposure and here you have the calcium hydroxide lining. If it goes about direct method, so a small increment of hard satin calcium hydroxide cement is placed in the deepest aspect, but only if pulp exposure is evident or a micro exposure suspected, as in this case you can see. And calcium hydroxide material is over here. And of course above it, temporary dressing in both cases. Indications for calcium hydroxide material are as follows. Indirect pulp capping. If it goes about indirect pulp capping, it is used in deep carious lesions that are close to the pulp, so-called nearly exposures that can be seen in cases of traumatic tooth fracture. During excessive preparation, the pulp is often visible through the remaining dentine as a pinkish or reddish spot or area. Direct pulp capping, deep carious lesions, that is accidental exposure during probing. It goes about acute deep caries. Traumatic fractures of the tooth, it can be habitual trauma, and iatrogenic exposure during cavity preparation. Pulp is exposed in one point. When it goes about iatrogenic perforation, we can think about such imaginary case when old restoration were removed and due to proximity to the pulp tissue, accidentally the pulp horn were exposed. So generally these tooth considered to be healthy, but such iatrogenic exposure accidentally occur. Techniques for placement of therapeutic lining. So a small ball-ended instrument is used to place the satin calcium hydroxide material in a thin layer, no more than 0.3 millimeters, to the whole floor of the carious cavity or to the deepest aspects of it on the projections of pulp horns, as you can see in this case of indirect pulp capping and direct pulp capping directly to the exposed pulp horn. Calcium hydroxide material is left inside the carious cavity for 14 days and of course is covered by temporary dressing. Such a treatment plan is proposed. On the first visit, antiseptic treatment of oral cavity using solution of chlorhexidine, 1%. Necroectomy, the next essential step. It means that all decayed tissues should be removed. If some are left, medicaments can be inactivated due to the presence of microorganisms and their toxins. Thus, treatment is compromised. So this step of necroectomy is critical. Next, after necroectomy goes applying of calcium material. It can be direct or indirect technique, using ball-ended flat plastic instrument, gently distributing it in a thin layer. Calcium hydroxide material is prone to fracture in thick layers. That's why this thin layer, like a biofilm of a thickness 0.3 millimeters, is necessary to maintain in order to prevent fracture. And if this layer is fractured, calcium release is compromised. That's why it is recommended to follow instructions. If there is a pulp exposure, bleeding should be stopped with hemostatic liquids, for example, hydrogen peroxide or any other hemostatic liquid. Caries cavity should be dry to overlay the liner. Actually, calcium hydroxide material is sensitive to moisture, and in the presence of moisture, it is soluble and it won't work at all. There would be failure of this material. Dryness of caries cavity is the next, after necroectomy, important step in treatment plan. And after material was aligned to the caries cavity bottom, a small ball of cotton is laid above it, and after the cotton ball, a temporary dressing is imposed. Material is left in the caries cavity for 14-21 days, and this time is sufficient for formation of dentine bridges. On a second visit, removal of temporary dressing is done, and caries cavity bottom is checked by probe. If patient don't have any complaints, no pain during probing, then final restoration can be done. Material of choice in this case, of course, glasionomer due to fluoride release, or can be recommended sandwich technique. In a case of even minor pain, increased reaction for thermal stimuli, positive percussion and decreased electrical excitability of pulp, or the presence of at least one of these symptoms, it is indicative to repeat the treatment. It means to repeat overlaying of therapeutic lining with calcium hydroxide material. After retreatment with therapeutic lining, if results are unsatisfactory, the inflammatory process increases, then conservative therapy should be stopped and replaced by surgical treatment. Such available materials can be used as liners for pulp protection. It is calcium hydroxide material, chemical, polymerized, and light activated. They are available in such formulations: paste formulation, suspended in solvent calcium, and light activated calcium hydroxide material. Other option is dentine bonding agents and mineral trioxide aggregate, MTA material. Here you have the properties of calcium hydroxide lining. It has the greatest pH, from 9 till 12 pH, and actually this creates a cytotoxic effect that stimulates the formation of a secondary dentine. Due to these high pH levels, calcium hydroxide is bactericidal, and in this alkaline environment, any microorganism can survive. So it kills microorganisms as well. Moreover, it is easy to manipulate with this material. It has rapid hardening in oral environment. It is very positive criteria, but it has as well drawbacks. It is soluble in acids and washed out if there is no tight obturation by temporary dressing. Calcium hydroxide does not bond to dentine, and micro leakage can occur over sufficient period of time. Calcium hydroxide materials can't be left under final restorations because they have the ability of resorption. Actually, it is explained in this way. As calcium resorb, in this time, this material release calcium into tissues. So, if calcium is placed under the final restoration, in a time there would be a micro space between tooth surface and restoration, and it can lead to fracture of crown restoration and failure of it. That's why it is not recommended to put calcium material under the final restorations. Available formulations of calcium material: suspended in solvent, when evaporated leaves behind a layer of calcium hydroxide. Paste formulations, they release more calcium in comparison with light curing calcium hydroxide materials. And light activated materials, they are acid resistant, not non-soluble, and can be placed under resin composites because they are strong enough and they have no ability to resorb. But light activated materials indicated in the case of indirect pulp capping, so nearly exposures. Only in this case, this material, light activated, is indicated. Such brand names can be used as examples of material. So we have Daical, Densply, and Material Life Care company care. So Daical, Densply, it is calcium hydroxide material that can be used both for direct and indirect pulp capping. According to their instruction that manufacturer gives to us, it is strong enough material. It can stand high compressive strengths. It is low. It has low solubility, and it can even stand the forces of amalgam. That is the recommendation of manufacturer. Life material company care, similar calcium hydroxide base hard satin material, indicated for direct and indirect pulp capping. It is available in two tubes, both Daical and Life. One is base and another tube is catalyst, mixed together in equal proportion, and then due to chemical setting reaction, polymerized in oral cavity under the temperature of it. Light activated materials for indirect pulp capping. Such examples: Calcicur, company Voco, and Calcimol, LC, as well Voco. These materials have similar pH level, non-soluble, acid-prone, indicated for indirect pulp capping. Once again, I will stress on it. Mineral trioxide aggregate MTA material. It were developed by Mahmoud Torabinejad as a dental root repair material in 1990s. The composition: powder composed of small hydrophilic silicate, phosphate, and tricalcium oxide particles with the addition of silicon oxide and bismuth oxide, which make it X-ray contrast. It has such properties. pH level is 10.2 after mixing and 12.5 after curing. So as well, it possesses antimicrobial activity. And actually, the level of pH is similar to calcium hydroxide materials. It is biocompatible material, it does not react or interfere with any other restorative material. It has low solubility. It means that it works well even in the presence of moisture. Such recommendation available that moistened cotton should be placed in contact with MTR before placement of the permanent restoration. As it seems, this material even needs some amount of moisture for setting. But it is not strong enough. So it has low resistance to compression, but actually the developer of this material don't put in front of him to make this material strong enough, because initially that MTA were designed for root perforations or perforations of bifurcation of the roots. The setting time is around 3 or 4 hours. Such examples of MTA we have Biodentine, company Septodont, and ProRoot MTA, company Dentsply. According to instructions, this material can be used for apical formation, repair of iatrogenic perforations, repair of absorptions, retrofilling, and coating of the pulp, and of course pulpotomy procedures. New approaches in direct pulp capping. Numerous studies have shown that calcium hydroxide material should be considered as the gold standard for the treatment of iatrogenic pulp exposures, by stimulating the formation of dentine bridges and consequently leading to pulp healing. New pulp capping techniques may stimulate pulp healing through complete dentine bridge formation with no chemical toxic effects, thus providing better results than calcium hydroxide material. In recent years, dentine bonding systems have been examined in humans and animals as a potential direct capping materials due to their superior ability to adhere to demineralized dentine tissues. And such criteria should be followed if it goes about direct pulp capping with dentine bonding systems. It is blood control. So bleeding is an unfavorable situation for this technique. That's why such method can be advocated in early exposures or iatrogenic pulp exposures during cavity preparation in a case if there is no bleeding. Otherwise, quality of technique is compromised. Such materials can be used. Basically, it is recommended to use total edge adhesive systems or self-edge systems. But self-etching systems, 2 steps, it's important, cause less bleeding in comparison to total edge. And here I put these examples of self-etching systems of 2 steps. It is 3M company at per prompt LPOP, self-etch adhesive, and Kurorai clear field, self-etching bond, as well 2 steps system. Necessary to say that ideas of researchers about this technique is controversial. Whether it is positive or negative result after this treatment procedure. That's why the research in this field is necessary to continue. Such guidelines for direct pulp capping with adhesive techniques are proposed. First of all, there must not be any endodontic symptoms at the time of the procedure. The patient should not report any kind of sensitivity of the tooth. Basically, accidental pulp exposure of healthy tooth. For example, if there is a replacement of old existed restorations, in such cases, this method of adhesive system applied as a pulp capping would have good results. Second guidelines, its minor accidental exposures must be treated in a caries-free environment if possible. That's why protection of rubber dam and coffer dam is essential. Swift intervention is essential in the case of pulp exposure caused by trauma. The tooth and mucosa affected by trauma must be disinfected with chlorhexidine-based solutions. Small areas of exposed pulp in young subjects have a better chance of healing. The tooth must always be isolated with a rubber dam. Obtain hemostasis of the exposed pulp through compressions with small sterile cotton pellets, moistened in a solution of hydrogen peroxide. Use of 3-step etching acid plus primer plus bonding or 2-step self-etch plus bonding adhesive systems. Cover the exposed pulp treated with adhesive systems with a layer of flowable composite. Actually, this will help pulp to maintain occlusal stress positively. So flowable composite is essential initial layer under the final crown restoration. Restore the tooth with direct or indirect techniques using composite materials. Perform periodic checkups in the first year, every 6 months, of course, with appropriate X-ray data. So we are on the surgical method right now. Surgical method of treatment means total or partial removal of pulp from previously anesthetized tooth or extraction of pulp after using devitalizing substances. So surgical method can be done either with amputation or extirpation technique. So what is amputation? Pulp amputation is done under local anesthesia. It is surgical removal of the inflamed coronal pulp with the subsequent medical processing of its root part by imposing of therapeutic liner and a permanent filling. Such indication for vital amputation: pulp hyperemia, acute limited pulpitis, chronic fibrous and hypertrophic pulpitis, acute and chronic forms of pulpitis of temporary teeth in the period of root resorption, and in permanent teeth in the stage of root formation. As well, pulp amputation is indicated to old-aged patients with sclerosed and obliterated root canals and when roots are severely capped. But once I want to return back and point your attention on this indication. Teeth on the stage of root resorption, it is temporary teeth of children, and teeth on the stage of root formation. It is teeth as well of children, but permanent teeth. So we talk here about apexogenesis and apexofication. We should think about these two terms in this point of indication. Technique of vital amputation as follows. Of course, the initial step, it is anesthesia to the tooth, then with a round burr for slow speed handpiece, roof of the pulp chamber is removed, and after that, with this burr, amputation of pulp chamber is done. going a little bit down into root canal orifices for a few millimeters. After that is applied antiseptic solution on a cotton ball and hemostatic liquid to stop bleeding. After bleeding was stopped, caries cavity and tooth cavity should be dried, and above orifices of root canal, remnants of the pulp tissue, should be placed calcium hydroxide material. Later, cotton ball and temporary dressing. And hopefully these tooth will stay vital. Next visit in a 14-21 days, and after that can be done final restoration. If there is no symptoms of progressive inflammation. Vital extirpation method. Pulpectomy, it's a synonym to extirpation, and actually the definition of this is as follows. It is treatment procedure by which entire pulp tissue previously anesthetized is surgically removed and replaced with the root filling. So such indication for this technique: traumatic pulpitis, acute trauma with fracture of tooth crown, acute diffuse pulpitis, acute purulent pulpitis, chronic hypertrophic pulpitis, pulp polyp, chronic gangrenous pulpitis, chronic calcified pulpitis or pulp stone. In general, vital extirpation method, it is widely used and recommended in almost all cases of pulpitis. It has such steps. The first step, it is anesthesia to the tooth, local anesthesia. Then caries cavity preparation, tooth cavity disclosure, pulp amputation, enlargement of root canal orifices, pulp extirpation, determination of root canal length, instrumental treatment of root canal, medicament treatment of root canal sealing using canal filler and paste or gutta percha techniques, and final crown restoration. Before talking about procedural steps of root canal treatment, propose for you to revise classification of endodontic instruments that are used for root canal treatment. This classification were proposed by Courson in 1996, and actually this is based on clinical usage of endodontic instruments. That's why it is comfortable for dentists. So we have diagnostic instruments. It can be root needles, Miller needles, or Pathfinder. Instruments for removing the soft tissues, it is barbed brooches. Instruments for passing, enlargement and shaping of root canals, such as K-reimers, K-files and H-files. Instruments for obturation, lentulospiral filler, vertical and lateral gutta percha condensers. Such treatment plan can be obtained in a case of vital extirpation of pulp. On the first step, anesthesia is done. Due to this fact that vital extirpation method, vital extirpation technique is quite long in time. Usually it takes hour and a half or even 2 hours for full treatment. So the use of injectable anesthesia in this case is advocated. It is carried out as a combination of regional nerve block and infiltration if necessary. For mandibular jaw bone, inferior alveolar nerve block is enough for appropriate anesthesia to treat pulpitis. And of course can be extra infiltration done to anesthetize buccal nerve if necessary, or lingual. For maxillary jawbone, only infiltration is used as a because maxillary jawbone is spongy. That's why it's porous enough. That's why local anesthetic can easily flow down into area around the apex and infiltrate the nerves, and thus anesthesia will occur. Injections is done in the projections of root apexes. Infiltration is advocated to maxillary jawbone. Once again, I will stress on this. Second step, it is caries cavity preparation. Removal of decay should be done carefully, and total removal of decay is important. The caries cavity should be widely opened to create a direct transition of its walls into the walls of the tooth cavity. Caries removal is essential for several reasons. First of all, removing of caries permits the development of an aseptic environment before entering the pulp chamber and radicular space. Second, it allows assessment of restorability before treatment. And third, it provides sound tooth structure so that an adequate provisional restoration can be placed. Unsupported tooth structure is removed to ensure a coronal seal during and after treatment, so that the reference point for length determination is not lost. So remember this point. And next step, it is tooth cavity disclosure. It is removal of pulp chamber roof, thus facilitates access to root canal orifices. The access to tooth cavity in anterior teeth should be midway between incisal edge and cingulum, and in posterior teeth from the occlusal surface. Access is done. Lining up burr with a preoperative radiograph will help to gauge the depth of preparation. The initial handpiece is turbine and fissure or round-shaped burr, and if enamel is prepared, the handpiece should be turned into slow-speed handpiece with a rose head burr that has sharp blades for easier cutting of dentine and removal of the pulp chamber. On this diagram, you have examples of access preparations in different group of teeth. Here you have in anterior teeth, like a triangle. It resembles the shape of the tooth crown. Ovoid, oval, like so this typical for premolars. Rhomboid, square or rectangular for molar teeth. In generally, it resembles the shape of the tooth crown, because you ought to keep in mind that under every cusp there is a pulp horn, and actually the pulp under the pulp horn usually is located orifices to root canal. So access should be done in such way that all canal orifices can be easily located. Such initial steps of tooth cavity disclosure: unroofing the pulp chamber, gaining straight line access to root canal orifices, here you have, final shaping of caries cavity and tooth cavity. In general, the caries cavity and tooth cavity should have both straight walls and be a single cavity. During the access preparation, the cervical bulge that overlies the canal orifices of the mesial-buccal and mesial-lingual canals is removed, and actually it permits straight line access as a result. Pulp amputation. So initial pulp amputation is done on the stage of tooth cavity disclosure and unroofing of pulp chamber. The rest amount of pulp tissue can be cut with burr for slow speed handpiece or excavator. Tooth cavity is washed with hydrogen peroxide or any other antiseptics to stop bleeding and clean tooth from debris. So you have this schematic representation of pulp amputation with excavator. Enlargement of root canal orifices. It is a necessary condition for full disclosure of the tooth cavity, and it creates easy access to root canal orifices. Normally it is done with Gates-Glidden burrs and piezo-largo drills. Here you have the Gates-Glidden burrs, here you have the magnifying view of the working end. It's like an elongated drop with sharp blades. But sometimes can be used small rounded burr for slow speed handpiece to cut this amount of dentine in the orifices of root canal. Advantages of enlargement of root canal orifices. First of all, it effectively decreases the curvature in the coronal part of the root canal, allowing straighter access for files to the apical part of the root canal. It allows improved access for the flow of irrigant solution, and it reduces the probability of apical extrusion of infected material, as most of the canal debris is removed before apical instrumentation. And this is particularly important because the majority of bacteria of an infected root canal are located in the coronal region. That's why preparation of orifices will decrease later contamination of root canal. The tooth cavity is properly disclosed when it completely connected with the caries cavity. Their walls pass into each other without irregularities, forming a straight line. Final shape of cavity should be such that all canal orifices can be easily located with small K file or other endodontic instruments. So it is the summary of tooth cavity preparation and gaining access to root canal orifices. Here you have the examples of access openings on the extracted teeth. In maxillary jawbone triangular, for incisors, such oval shape for canine. Here you have the clearly visible access to root canal orifices in the maxillary first premolar and molar with 3 visible root canals. And here you see this grayish depression on the floor of the pulp chamber. Actually, this is the place where pulp laid down. Here you have as well this grayish fissure. And this molar has 2 canals in mesial-buccal root. It is called MB2 canal, so extra canal. So such anatomy should be, you should know that such is possible and learn this possible peculiarities of molars. Mandibular molars and their ideal access openings in incisor, in canine. Pay attention to the shape. Premolar, molar, such almost square shape with 3 visible root canals, and here it is rectangular, but this tooth has 4 canals, entrances to 4 canals. Pulp extirpation is the next step in root canal treatment. So for this purpose, I used barbed brooches. Here you have the working end, magnified, and barbed brooch with pulp tissue on it. So barbed brooches is inserted into the root canal to the 2 said lengths of the root canal, then rotate 180 degrees and pull together with the pulp. So generally it should be done 1 or 2 rotations to catch the pulp tissue. And if there is a feeling that pulp tissue is caught, necessary to pull out. For successful manipulation with barbed brooches should be observed such recommendations. to work with instrument only in a straight part of the root canal, not to push instrument inside the canal deeper than 2/3 of its length, not to force instrument into the canal, and do not use bulb broaches in canals with visible obliteration on X-ray, because it can lead to fracture of the instrument, and as a result there would be a problem in endodontic treatment. Successful endodontic treatment. On this stage of pulp extirpation, normally bleeding can occur. That's why for this bleeding control, I used such hemostatic liquids. Such examples I have prepared: racistiptin, Septodont, Technodent, Hemostop. Such materials are applied on the small cotton ball and put into the pulp chamber closely to the root canals orifices for a few minutes to stop bleeding. Nevertheless, if tooth was anesthetized, normally bleeding would be not so pronounced, would be small, but sometimes bleeding can occur. And vasoconstrictor actually are given to anesthetic solution to decrease the space of blood vessels, and thus the bleeding is controlled, and actually it's very minor. If tooth is anesthetized, then bleeding is minor, but still it is possible. So necessary to have such medicaments in a case of bleeding. Next step, it is the determination of canal length. So working length is defined as a distance from a predetermined coronal reference point, usually the incisal edge in anterior teeth and the cusp tip in posterior teeth, to the point that the cleaning and shaping and of course obturation should stop. Here you have this reference point on a cusp. Here you have the predictable apical constriction and rubber stop that is fixed in this point, so instrument won't go far. And now about apical constriction. Anatomy of it is actually the anatomical structure and anatomy of the apical part is of great importance in endodontic practice. So root canal treatment in case of pulpitis should stop at physiological apical hole or apical constriction, and it is located 0.51 millimeter away from anatomical apical hole, and it is defined at the border between pulp and periodontal ligament. And anatomical apical hole or apical foramen has such definition. It is a place of transition of the dentine into cement. But if it goes about pulpitis treatment, it should stop at this apical constriction or physiological apical hole. Why it is necessary to maintain correct working length. So it determines how far instruments can be placed, because as over or under instrumentation is harmful, determines success of treatment, hence the patient should not come back with pain. Working length may change as the curved canal is straightened. Failure of determining correctly should be avoided. In case of over-instrumentation, for example, going beyond the apex, there will be delayed healing. In case of under-instrumentation, not reaching the apex, then you might have left some necrosed pulp or viable bacteria that may cause reinfection or produce a cyst. Such important statement. Success of endodontic treatment directly depends on the success of determining the working length. Methods of establishing working lengths. Use of tables data of the average root canal lengths together with endodontic ruler, because instrument should be prebented according to this endodontic ruler to its average root canal length and then inserted into root canal. X-ray method and electronic apex locators. X-ray method. Essential initial step, it's preoperative radiograph. It must be taken before every root canal treatment to determine anatomy and morphology of the root canal. A radiograph of tooth with endodontic instruments to tentative working lengths as well important. And here you have actually this X-ray with endodontic instrument on it, and X-ray is done to determine if canal can be normally passed and to determine the working lengths. Electronic apex locators is electronic device that is used in endodontics to determine the position of the apical foramen and thus determine the length of the root canal space. Apex locator has such parts: lip clip, file clip, electronic device, and cord that counteracts these three parts. Such prerequisite for using the apex locator: complete debridement of the root canal. There should be no debris or necrotic tissues. Canal should be dry. No blockage or calcification of canals. Proper contact of file with the canal walls and apex, and proper equipment. Instrumental treatment of root canal. Debridement of the root canal space includes removal of vital and necrotic tissue, bacteria, bacterial byproducts, and dentinal debris that were created during the cleaning and shaping process. And actually, debridement, it is explanation of instrumental treatment of root canal, and it embraces cleaning and shaping. Cleaning refers to the debridement of root canal space. Shaping is the step of root canal preparation for obturation. All clinically accepted endodontic instruments and instrumentation techniques attempt to perform both processes simultaneously together with irrigation, because it is essential step in instrumental treatment. Instrumentation and irrigation. Instrumental treatment of root canals is done using hand endodontic instruments in a sequence. And we have such steps in this instrumental treatment: root canal passing, root canal enlargement, root canal shaping. It is done by hand endodontic instruments. They are as follows. K-reamer is used to pass through root canal. K-file is used to enlarge the space of root canals. H-file is used to shape the root canal, removing all irregularities of the wall that possibly occur on the previous stages of endodontic treatment with K-reamer or K-file. According to ISO standardization, all endodontic instruments have their geometric symbols and color coding. So geometric symbol of K-reamer is triangular, K-file is rectangular, flexo-file is rhomboid, H-file is circle. Color coding, here you have this scale. So all of this facilitates dentist work. Dentist can easily pick up all necessary instruments because he see what is the instrument according to the geometrical symbol, and can choose the size of instrument according to the colors on the handles of the instrument. And size means diameter of the tip of the instrument. And actually it is as well called taper. So endodontic instruments have such criteria: taper. It means that with every millimeter gained in length of the instrument, its taper increases by 0.02 millimeters. So generally they have the conic shape is a predictable step, 0.02 millimeters. Endodontic instruments, hand endodontic instruments, works in two motion, filing and reaming. In a filing motion, the instrument is placed into the canal at the desired length. Pressure is exerted against the canal wall, and while this pressure is maintained, the rake of the flutes rasps the wall and the instrument is withdrawn without rotation. So in general, it works in a push-pull motion without any rotation movements, because the rotation can eventually lead to fracture of the instrument, because headstrong file, their working end resembles screw-type instrument, and if rotation is done, it means that it's screw into the root canal, and fracture can easily occur if such is done. So necessary to remember that H file, headstrong file, and K file works with filing motion. Reaming is a method that produces a round tapered preparation, and this is used only in a perfectly straight canals. In such a situation, reamers can be rotated 1/2 turn before retracting. So reaming means rotation. In this motion works K reamer and K file. Pay attention. K file can work both with reaming motion and filing motion, but H file only in filing and K reamer only in reaming. It's necessary to follow this recommendation in order to prevent fracture of the instrument. Fracture leads to problem in endodontic treatment. Manipulations of root canal treatment are carried out manually or with the help of rotary instruments by several treatment methods. The most widespread among them are apical crown method. It means that instrumentation starts from the apical part of the root canal, moving upwards to the coronal part. Crown apical opposite, from the coronal part, moving downward to the apical part. And combination of these two methods, hybrid method, has such idea that instrumentation starts as a coronal method, crown apical, moving to the middle part of the root canal, and at this distance it's stopped and transversed into apical crown, moving from the apical part to the coronal part of the root canal. Apical crown method is represented by step-back technique. So the apical part of the root canal is prepared first and then enlarged. So canal is enlarged from the apical part to the coronal part. But initial step in the step-back technique is preparation of root canal orifices with a Gates Glidenburg. Then apical preparation is done to the desired master apical file. Here you have master apical file, means that it is the last instrument that is used to prepare apical portion of the root canal. And after that, instrumentation goes ahead, changing instruments in a turn, K file, H file, and at the same time taking instrument in appropriate sizes from smallest to biggest. But don't forget about recapitulation. So recapitulation with a small K file is done to smooth canal and to ensure that the canal is not blocked. So recapitulation means to take instrument one size smaller than the previous was, and then continue treatment. And after every instrument should be taken one size smaller, and then again to that size that were used for preparation of the canal at this stage. Finally, all irregularities of the root canal is shaped with H file, and the canal at the end should obtain such smooth conic shape. It means it is ready for obturation. Of course, irrigation of the canal should be done following every instrument. Irrigation not only kills microorganisms, but also facilitates placement of instrument inside the root canal. So we have such advantages of step-back technique. Less periapical trauma, more debris removal, increased condensation pressure can be applied, and disadvantages: extrusion of debris, apical blockage, tendency of canal deviation. Crown down technique. So this, according to this technique, root canal is prepared from the coronal part, moving downwards to the apical part. This technique is preferred when it goes about rotary instrumentation of the root canal. So such steps it has. Coronal pre-enlargement with Gates Glidenburs. And then taking instruments in a sequence from the biggest sizes, approximately 25, going downward, taking instruments from the biggest to smallest sizes. And as well, don't forget about recapitulation. This is essential both in crown down and in step back technique, because it helps to keep the wall of the root canal smooth without ledges. And as well, antiseptic is done. Because antiseptic is essential when it goes about instrumentation of the root canal. Biological benefits of crown down: removal of tissue debris, less post-operative sensitivity as it is a pressure less technique, hence there is no extrusion of debris into the periodontal ligament, better irrigation as coronal obstructions are removed, better tissue dissolution and the irrigation is improved, rapid removal of contaminated tissues. Lanced force technique. So this involves using blunt tipped files with an anti-clockwise rotation whilst applying an apically directed force. It requires practice to master, but it's particularly useful when preparing the apical part of severely curved canals. Such procedural steps. In the balance force technique, the file is placed to the working length and rotated clockwise 90 degrees with a light pressure to engage the entine. Then file rotated counterclockwise 120 degrees while apical pressure is maintained to cut and enlarge the canal, and debris is removed with a final clockwise rotation that loads the flutes with loosened debris and push it out from the root canal. So that is the idea of balance force technique, basically used for curved root canals. In order to prevent perforation of the wall. Short summary of these steps. So debridement of the root canal space includes removal of vital and necrotic tissue, bacteria, bacterial byproducts, and dentinal debris that were created during the cleaning and shaping process. And of course, irrigation and disinfection are integral parts of the debridement. So next step, it is antiseptic treatment of root canal. But nevertheless, instrumentation and medicamental treatment should go hand by hand. We cannot separate these steps. But here I have put them in such order. So intracanal medicaments have a long history of use as interim appointment dressings. They have been employed for the following three purposes. Here it goes not only about antiseptics, but for medicaments that can be used for root canal. So such purposes of medicaments: to reduce inter-appointment pain, to decrease the bacterial count and prevent regrowth of them, to render the canal contents inert. Key facts about irrigants. Irrigants are required to flush out debris and to lubricate instruments. First, important. Second, dilute sodium hypochlorite is generally considered to be the best irrigant as it is bactericidal and dissolves organic debris. The normal concentration is 2.5 available chlorine. Chelating agents, which softened in time by their demineralizing action, are particularly helpful when trying to negotiate sclerosed or blocked canals. It is recommended to coat instrument in antiseptic solution every time it is inserted into root canal, because irrigants not only cleans the root canal but also dissolves flakes of debris on the working part of the instrument. As well, important statement. Irrigation does not completely debride the canal. Sodium hypochlorite will not remove tissue from areas that are not touched by files. In fact, no techniques appear able to completely clean the root canal space. So keep it in mind, this statement. And frequent irrigation is necessary to flush and remove the debris that were generated by the mechanical action of the instruments. Delivery of irrigants by using endodontic needle and syringe and by coating endodontic instrument in antiseptic solution every time it is inserted into root canal. Here you have the design of endodontic needle. It has blunt tip and opening on a lateral border. And actually it is very good design because it prevents direct flowing of antiseptic into periapical tissues, but instead only coating and washing of walls. So endodontic needle should be inserted only to the one third of the root canal length. Mainly it should be placed to the root canal orifices. It should stay free inside the root canal for proper irrigation. To facilitate placement of needle into tooth cavity, it is recommended to bend it. In this table you see the most common intracanal medicaments. They are grouped in such way: phenolics, eugenol, aldehydes, pharmacresol, for example, halides, sodium hypochlorite, as well steroids, can be calcium hydroxide, antibiotics, and combinations of these medicaments. So that are the most common intracanal medicaments that are used in endodontics to treat the root canal for different purposes. Sodium hypochlorite, it is the gold standard and the most used one antiseptic if it goes about pulpitis treatment. Due to its toxicity, extrusion of this material should be avoided, and for that reason root canal preparation should be stopped at apical constriction. So normal correct root canal preparation will prevent extrusion of sodium hypochlorite out of the apical part. So the irrigating needle must be placed loosely in the canal. Insertion to binding and slight withdrawal minimizes the potential for possible extrusion of sodium hypochlorite in periradicular tissues. And special care should be exercised when irrigating a canal with an open apex. For that reason, sodium hypochlorite mainly recommended for treatment of pulpitis, and to some extent should be avoided if it goes about apical periodontitis, because there is a possibility of extrusion into periapical tissues, and in this way could develop toxic apical periodontitis. Another antiseptic material, it is chlorhexidine. So chlorhexidine possesses a broad spectrum of antimicrobial activity. It provides a sustained action and has little toxicity. 2% chlorhexidine has similar antimicrobial action as 5.25% of sodium hypochlorite. Actually, sodium hypochlorite is available in different ranges, but the widely used is 2.5% of sodium hypochlorite. Chlorhexidine, for instance, is more effective against Enterococcus faecalis. Disadvantage of chlorhexidine is its inability to dissolve necrotic tissue and remove the smear layer, and sodium hypochlorite actually has its ability. It not only acts as antimicrobial medicament, but also dissolve necrotic tissue. So it's very good criteria for sodium hypochlorite. Here I wrote a note that sodium hypochlorite and chlorhexidine cannot be used at the same time because they provide adverse effect on one another. Due to their simultaneous use inside the canal, due to chemical reaction, can develop flakes, and actually these flakes can block root canal space, and thus endodontic treatment is compromised. So necessary to choose which antiseptic to use, either sodium hypochlorite or chlorhexidine, but never combine them together. If it goes about sclerosed and obliterated root canals, it is impossible to work without decalcifying agents, because the main task of these decalcifying agents to dissolve sclerosed and obliterated dentine and facilitate easy passing of endodontic instrument through the root canal. Such examples of the calcifying materials here I put, so it can be canal plus septodont or root canal enlarger based on ETA. They introduced either with from syringe as canal plus, or they can be placed on a cotton ball inside the root canal and wait for a few minutes to vaporize, and thus to promote decalcification of dentine. This table gives you information about materials that are used for this purpose of chemical enlargement. Basically, they are divided in such groups: solution of ETA, Largal Ultra, Endofrieden Care, solution of citric acid and propionic acid, very fixed, and gels that are based on ETA. It can be Canal Plus, RC Prep, and of course other available materials. Next step, it is root canal sealing. After root canal were appropriately instrumented, washed, it should be dried. Into the dry root canal, a root sealer is placed. What are the objectives of root canal obturation? First of all, to prevent bacteria and bacterial elements from spreading from or through the canal system to the periapical area. The fully instrumented root canal has to be provided with a tight and long-lasting obturation. A root canal filling material should therefore prevent infection, reinfection of treated root canals, together with an acceptable level of biocompatibility. It should be inert material. This will provide the basis for promoting healing of the periodontal tissue and for maintaining healthy periapical conditions. The most popular sealers are grouped by type: zinc oxide eugenol, glass ionomer, paraformaldehyde sealers, calcium hydroxide, and resins. If it goes about pulpitis treatment, the sealer of choice would be zinc oxide eugenol cements and resins. Of course, paraformaldehyde sealers can be used if it goes about devitalized methods of treatment, especially devitalized amputation. Regardless of the sealer selected, all are toxic until they set. For this reason, extrusion of sealers into the periradicular tissues should be avoided. So keep this statement as well in mind when it goes about root canal sealing. Zinc oxide eugenol sealers have the advantage of being resorbed if extruded into the periradicular tissues. Also, this group of materials provides an anti-inflammatory action to the periradicular tissues because they contain steroid anti-inflammatory drugs in their composition. Such examples: Dexodent, Alpha Vita, and Tublicil Company Care. Dexodent, it is powder mixed with eugenol liquid and inserted into root canal with the help of Lentulo spiral filler. Sealers that contains paraformaldehyde, actually they are contraindicated in endodontic treatment in United States of America. But in our country it's used. Contraindicated because they considered to be cancerogenic formulations, and they were replaced by other materials. But if it goes about devitalized method of treatment, these materials can be used in the case of sclerosed and obliterated root canals, when instrumental treatment cannot be held normally to the full length. As a result, the paste on the basis of paraformaldehyde is applied only at the root canal orifices. So in this case, the mummifying of the pulp is conducted. So please remember this term, mummifying. Epoxy resins are available in paste-based formulations. Here you have examples: H+, dense ply, Adsil, Meta. These materials are used together with gutta percha points. Available in 2 tubes, so equal portions are mixed and then inserted into root canal following certain techniques of root sealing with gutta percha. And we have such techniques that is used together with gutta percha. It is solid core techniques, single cone and lateral compaction, warm lateral compaction, warm vertical compaction, thermomechanical compaction, core carrier, and injection molded gutta percha. Single cone technique. In this technique, the main idea is such that gutta percha point should tightly obturate the apical part of the root canal. For this reason, the size of gutta percha point should be selected the same as the master apical file was. Master apical file means that instrument that were the last to shape the apical portion of this root canal. Technique is such that material sealer is placed into root canal and then inserted gutta percha point to the apical part, and the excess of gutta percha is cut with hot instrument, and that's it. The end of treatment in a case of single cone method, called lateral condensation. This is a commonly used method for obturation. It's considered to be the gold standard. So the technique involves placement of a master point that is chosen to fit the apical section of the root canal. Obturation of the remainder is achieved by condensation of smaller accessory points. The steps involved are: first of all, select master point. It should correspond with the master apical file, and this should fit the apical region snugly at the working lengths, so that on removal a degree of resistance or tug back is felt. If there is no tug back, select a larger point or cut 1 mm at a time off the tip of the point until a good fit is obtained. The point should be notched at the correct working lengths to guide its placement to the apical constriction. Take radiograph to confirm that the point is in correct position. If you have doubt about it, coat walls of canal with a sealer using a small file, then insert the master point covered in cement. Then condense the gutta percha laterally with the finger spreader to provide space into which accessory points can be inserted until the canal is full and excess gutta percha is cut off with a hot instrument, and the rest of gutta percha is packed vertically into the canal with cold plugger. Here you have this sketch that shows you how lateral condensation looks at a cross section. So it is apical part and it is a coronal part of the root canal. In such way it looks. So tightly obturation is in the apical part. In the coronal part we see these spaces, it is sealer. But the main task to tightly obturate apical part of the canal, thus to form blockage between periapical tissues and root canal space, to block the apical part. From lateral condensation as above, but uses a warm spreader after the initial cold lateral condensation. Finger spreaders can be heated in a flame or a special electronically heated devices. Touch of heat can be used. Here you have this sketch of how the warm lateral condensation is done. And vertical condensation. Small parts of gutta percha is inserted into canal and then condensed with a hot plugger, and this is repeated until the all space of root canal is filled with gutta percha and finally pressed with a cold plugger. And finally we have crown restoration. So both design and placement of the final restoration are critical, and this aspect of treatment is an integral part of obturation. The restoration acts as a protector of tooth structure. It's important. If the myriad of irritants in the oral cavity gain access to the periapical tissues, they may cause inflammation and treatment failure as a result. Irritants can be such substances of saliva, microorganisms, food, chemicals, or other agents that pass through the mouth. If coronal gutta percha with sealer obturation is exposed to saliva, dissolution of sealer and leakage over a relatively short period of time may occur, and this results in leakage of bacteria, toxins, and chemicals into and around the gutta percha. The consequences of sealer loss are obvious. Communication from the oral cavity to the periapex or periodontium will eventually be complete via lateral canal or apical foramen. Coronal exposure of the obturating material for more than a short period of time through loss of restoration, recurrent caries, or open marges requires retreatment. So if there is a coronal exposure, root canal treatment is compromised, and it's necessary to do retreatment of the root canal because gutta percha is a good pathway for microorganisms to flow directly into periapical space. The time of exposure requiring retreatment is undetermined, but probably depends on varied factors such as quality of obturation, length of canals, and surface area of exposure. That's why final restoration its quality is important in maintaining these tooth healthy. Together with vital methods of treatment that are typical for surgical methods, we have devitalized methods. And devitalized methods can be devitalized amputation and devitalized extirpation. So amputation method is of rare use today in modern dentistry. Actually, it is indicated in such cases. Treatment of pulpitis in molars with severely curved roots. Thus, endodontic treatment of root canals is hard. Treatment of pulpitis in old-aged patients to whom anesthesia is contraindicated. Those who have somatic disorders such as hypertension, blood diseases, when root canals are sclerosed and obliterated. And treatment of pulpitis in patients with allergy to anesthesia. Technique of devitalized amputation is followed. Tooth cavity disclosure with a round burr, pulp amputation of coronal part of the pulp tissue, then applying of paraformaldehyde paste to the root canal orifices, cover it by small cotton ball, and close with a temporary dressing from zinc sulfate cement or dentine paste. It was the first visit. On a second visit, the temporary dressing is removed and remaining pulp is covered with a mummifying paste. For a dent, for example, it is rather thin formaldehyde paste that is covered with a cement filling. Duration of paraformaldehyde paste inside the carious cavity, tooth cavity, should be 10-12 days if it is paraformaldehyde. If it is arsenic paste, then it should stay from 1 till 3 days. And if it goes about paraformaldehyde or arsenic, but arsenic paste in particular, tight obturation of temporary dressing is important, because if micro leakage is evident, arsenic paste can cause necrosis to the gum tissues, if it is proximal cavity or if it is cervical cavity. Devitalized extirpation indicated in such cases. Different types of pulpitis in patients who have allergy to anesthetic solutions. Devitalized extirpation is held in 2 appointments. On the first appointment, pulp is devitalized using devitalizing agents, similar technique to that of devitalized amputation is done. And on a second appointment, pulp extirpation is done to the full length of the root canal, following appropriate steps of instrumental treatment technique, and antiseptic of the root canal is done as well. And after normal root canal obturation with appropriate sealing material should be done. Available materials for devitalized methods of treatment. Devit S non-arsenic paste for pulp devitalization. It has in its composition paraformaldehyde paste. That's why it is non-toxic to periradicular space, and according to instruction, it can stay in the pulp chamber during 3-5 days, and in this time the complete devitalization of the pulp occur, and in rare cases, it depends from the number of roots, it's necessary to stay in the tooth cavity for 7 days. with ars, such material, arsenic-based, is used for pulp devitalization during 24-48 hours, depending on the two structures, single root or multi-root. Time of material present in tooth cavity should not exceed 72 hours according to instructions of manufacturer, and to avoid arsenious necrosis, the patient should come to dentist in case of paste leakage. Moreover, if patient don't come for dentist on the time of appointment, it means more than 3 days of this paste being inside the caries cavity, there is a possibility of toxic apical periodontitis development. And in conclusion, I can say such: the choice of treatment option depends on the level of pulp inflammation, it means type of pulpitis, topographic and anatomical peculiarities of the tooth cavities, and root canals, of course, and of course general state of the human organism. The key fact to the choice of treatment is anamnesis should be thoroughly collected, should be done appropriate main and extra methods of diagnosis, and if everything is done of that is listed here, in this case, a correct method of treatment can be chosen for a certain type of pulpitis. And here I want to say that father of modern dentistry, Sir Green Vardiman Black, in his days, he says such statement that the day will come, and maybe you will all live to see it, where we will practice preventive instead of reparative dentistry. And actually it makes sense, and we should think more about prevention of caries and its complication nowadays. And only in this case our work would be effective. So such references here you have, and I propose you to read these books, because without reading certain books that are devoted to the endodontology, it is impossible to learn correctly and appropriately. Without Ingalls of Endodontics, it's impossible to know endodontology, it is to my mind. So this book I recommend as a further reading, Endodontics Principles and Practice by Mahmoud Torabinejad, textbook of endodontology, and endodontology publisher SEAM. So thank you for attention and good luck to you.